Yes, once again, thank you so much for joining. And now I will pass you over to Professor Andrew Horne.
Thanks very much, Gillian, and thanks for inviting me to give this lecture. I'm going to talk for about half an hour, give a sort of overview to managing and diagnosing endometriosis, and then I've left plenty of time for questions. And I think Gillian maybe asked people if they could bring some questions along with them for after the talk. So I'll just get my slides up. Great. So I'm a consultant gynecologist based in Edinburgh, and half of my time I spend in the clinic. I run an endometriosis and a pelvic pain centre, which is multidisciplinary, and then the other half of the time I do research for Edinburgh University, which is largely on pelvic pain and endometriosis. Endometriosis, as I'm sure you're all increasingly aware from all the media publicity, is incredibly common. It's as common as diabetes in women. It's said to affect 1 in 10 women and those assigned female at birth. And that equates to around 1.5 million women within the UK, 190 million women worldwide. And there's a lot of debate at the moment around the definition of endometriosis, but we're still sticking with a definition which is very much focused on lesions, and lesions are endometrial-like tissue found anywhere outside the uterus. The commonest site, of course, is within the pelvis, but you can get extrapelvic endometriosis, thoracic and umbilical disease, and even iatrogenic endometriosis, so caesarean scar endometriosis. Within the pelvis, there are 3 agreed subtypes: superficial peritoneal disease, which is disease found on the peritoneal lining within the pelvis, and these are often small, diffuse type lesions. Deep disease, previously called deeply infiltrating disease, which often come in the form of nodules and often involve the bladder and the bowel. And then, of course, ovarian disease, which are these ovarian endometrioma or chocolate-like cysts, as you can see in this image here. Endometriosis, however, is very heterogeneous. As I've said, there are these 3 subtypes, but even within the peritoneal subtype, you see different appearances of endometriosis. The blue-black lesions you probably remember from undergraduate textbooks, red lesions, white lesions. So very difficult to kind of classify the disease. But of course, endometriosis isn't just about lesions. It's about the symptoms that are often associated with it. The pain is the primary symptom, and that can come in the form of chronic pelvic pain, acyclical pelvic pain, dysmenorrhea, or pain with sex, pain with passing urine, pain on defecation. But endometriosis is also associated with a range of other symptoms. It can affect mental health, it can be associated with fatigue, it can be associated with difficulty getting pregnant, and a range of bowel symptoms such as diarrhea, constipation. And because of its association with adenomyosis, it's also often associated with heavy menstruation. What causes endometriosis? Well, this is the million-dollar question, something that we're very interested in Edinburgh. We focus very much on trying to better understand what causes peritoneal disease, and we've focused on the theory that it's partly due to retrograde menstruation, which was a theory put forward by a gynecologist called Sampson back in the 1920s. The problem with this theory is that 80 to 90% of women experience retrograde menstruation. So why in some women the tissue, the ectopic tissue, adheres, invades, forms its own blood and nerve supply is a big question. And even more difficult to understand is why women with endometriosis experience pain. The lesions, as I say, do form their own nerve supply. We do see an influx of immune cells into the lesions, the generation of cytokines, all factors which can generate pain. But increasingly we're better understanding the role not only of the peripheral nervous system in the generation of pain, but in the central nervous system in the generation of pain. And in fact, women with endometriosis who experience pain actually have a larger volume of cerebral cortex. So lots to try and better understand the condition. The other big problem is that about half the patients who have lesions don't necessarily experience painful symptoms. So it's certainly something very complicated. The other thing that we don't really understand is whether or not it's a progressive disease. So does mild disease progress into severe disease? And that's partly because we don't really know the natural history of the condition, because there aren't studies which have followed up patients in the long term. And the only actual information we have about endometriosis in terms of whether or not it's a progressive disease is actually from baboons. So baboons are primates are the only animal who spontaneously develops endometriosis, and studies in baboons have shown that in some baboons endometriosis just completely disappears without treatment, and some baboons it seems to progress. So a bit no further forward from studying this animal. Endometriosis, as I'm sure many of you are aware, is difficult to diagnose, and this has been largely attributed over the years to three factors. First of all, lack of awareness amongst clinicians, amongst ourselves about the condition, about the red flag symptoms which should precipitate referral, but probably more so because of the fact that patients with suggestive endometriosis present with a range of symptoms which are shared by other chronic pain conditions like IBS and bladder pain syndrome. And this has been compounded by the fact that we don't have a good non-invasive biomarker blood test or urine test for diagnosing endometriosis, and we of course rely on surgery to diagnose the condition. There are now published by NICE, this is from the NICE guideline which I'd urge you to look at, which was published in 2017, a range of, if you like, sort of red flag symptoms and signs for endometriosis. I'm sure most of you are aware of them, but the main thing is any symptom, particularly pain symptom, that has a cyclical pattern to it. And that doesn't necessarily just mean it falls during menstruation, but it could fall mid-cycle or prior to menstruation. Ultrasound is of course useful for ovarian disease. It will identify the larger ovarian endometrioma. This is an image, an ultrasound image showing the characteristic ground glass appearance of an endometrioma. And as we're getting better and better at ultrasound and also at interpreting MRI, as well as picking up ovarian disease, we can pick up deeper nodules. And in some cases, particularly in London and in Canada at the moment, there are some centres who are using ultrasound to diagnose peritoneal disease. So we are moving forward within this biomarker area. The main thing that is, if you do send a patient for a scan with suggestive of endometriosis, is of course don't exclude the diagnosis if the ultrasound is normal. And the other thing is don't use a CA125 as a test for endometriosis, because of course it's very non-specific. It does go up in cases of the disease, but it's not helpful as a diagnostic test. What should we be doing if we see a patient in the first instance with symptoms suggestive of endometriosis? Well, it's perfectly reasonable to discuss with the patient that they might have underlying disease, but give them the option of a short trial of treatment. And this could be in the form of a non-steroidal anti-inflammatory drug for 3 months, or any hormonal treatment, the combined pill or progestogen for 3 months. The important thing is, of course, to give them the option of an immediate referral to secondary care for further investigation. But the other thing that's important is that if these trials aren't effective, again, to consider referring them to secondary care. And again, this is published in the NICE guidance. And of course, if you see a patient with symptoms suggestive of endometriosis where fertility is a priority, then they should really be referred to a local fertility centre or fertility specialist for further investigation. When should you, when are the other instances of considering referral to secondary care? Well, severe, persistent or recurrent symptoms of endometriosis. If you see a patient who has obvious pelvic signs, so if you examined them and they had a mass suggestive of an endometrioma, either per abdomen or per vagina. And as I say, if initial simple management is not tolerated or contraindicated. And in any patient in whom you suspect, and this probably isn't going to come up much in general practice, but if you suspect they've got deep disease that's involving the bowel, bladder and ureter, they should be referred to a BSG accredited centre. So the BSG is the British Society of Gynecological Endoscopy. And I think just over 10 years ago now, they prepared criteria for hospital centres to get accreditation in the management, largely of complex surgical endometriosis. There are 3 centres in Scotland, Edinburgh, Glasgow and Aberdeen, and a further 50 or so centres scattered throughout England. So in those instances, referral to a centre should be considered. The most important thing about patients who leave secondary care and get referred into leave primary care and get referred into secondary care is, I think, the fact that they're given a multidisciplinary approach, a holistic approach to their treatment. This can obviously includes a gynecologist, usually a specialist nurse, sometimes a colorectal surgeon, a urologist, sometimes a pain medicine specialist. Our team also has a pain psychologist, a physiotherapist, and a specialist nurse. I can just see a hand up, Gillian. Is that somebody who's trying to ask a question?
I think it might be.
Yeah, it's Thea. Thea, you've got your hand up. Are you wanting to ask a question?
Shall I unmute?
Sorry, just my mistake. I'm sorry about that.
No,
well, that's
no
fine.
problem.
Don't worry. And then broadly speaking, management in secondary care is split into treatment by surgery to either remove or destroy the disease, and there's lots and lots of discussion you'll see on social media about whether ablation or excision is better, and I think really we don't know the answer to that. And then any hormonal treatment which suppresses the production of estrogen from the ovaries, so that can range from the combined pill to progestogens through to the levonorgestrel releasing coil through to Implanon, etc. With regard to surgery, if we look at the pelvic subtypes, for superficial peritoneal disease we generally excise or ablate it. For endometriomas, we usually strip out the cyst wall, and sometimes if we can't get the whole of the cyst out, then ablate the base of the cyst. The challenge with ovarian surgery is, of course, that balance between preserving as much normal ovary as possible and preserving fertility in what is often a young patient who maybe hasn't completed their family. And then, as I say, with regard to the deep disease, because this is often involving other pelvic structures such as the bowel and the bladder, this tends to be limited to BSG specialist centres. But the problem with surgery is it isn't effective in all patients. Around 30 of patients found it's immediately not effective, and then in patients in whom it's effective there's a high recurrence of symptoms, and this is been estimated to be around 20% after 2 years after the primary surgery and up to 50% after 5 years after the primary surgery. And we don't really know whether this is due to the fact that new lesions have developed or whether lesions may have been missed at the time of the surgery, but I think it's probably because we don't really fully understand the mechanisms behind endometriosis associated pain, and ignores the role of the central nervous system and the peripheral nervous system, and for example the immune cells that are involved in generating pain. And on that note, we're quite fortunate in the UK at the moment that there are a number of trials running to try and better understand the benefits of surgery in endometriosis, the NIHR have put quite a lot of money into these 3 multi-centre trials, and I'll briefly tell you about each of them. Esprit 2 is a trial that I'm running in Edinburgh with my colleague Lucy Whitaker, and this is a trial where we're randomising patients who have symptoms suggestive of endometriosis and have a diagnostic laparoscopy which demonstrates only superficial peritoneal disease, and patients with their consent are then randomised either to have that disease excised or removed or to have no treatment at all, and then we're monitoring them for up to a year afterwards to see whether or not the excision or ablation is of benefit. And the idea here is to demonstrate hopefully that it is beneficial, because there's lots of discussion around that at the moment, but also potentially to identify groups of patients which respond best to surgery so that we can give patients better pre-operative advice. The Regal trial just started in March. It's run by a colleague of mine, Dr. Lucky Sarasat, in Aberdeen, and this is looking at management of recurrent endometriosis, and here patients are randomised either to surgery or to treatment with a GnRH agonist and HRT, and then again followed up in a similar way. And then Diamond is run by a colleague, Justin Clark, down in Birmingham. It's just about to start in the autumn, and this is looking at the management of deep disease to see whether surgical treatment is better than medical treatment, and you hear a bit more about that in the autumn when that trial starts. In this table here I've attempted to break down the different hormone treatments that we have available for managing endometriosis, put very briefly their mechanism of action, side effects, etc., and how they can be administered. So of course we have combined oral contraceptives, progestogens, we have antiprogestogens, but they're not currently available for use in the UK. GnRH agonists, which as I say are given with add-back HRT, and just about to become available in the UK are GnRH antagonists, which are thought to have a better side effect profile and can be given orally, unlike the GnRH agonists, which are given usually by a monthly subcutaneous or intramuscular injection. But none of these treatments stand out as being better than the other. Really, it's a balance between the side effects of all of these treatments and as to whether they work. So often patients feel like they're being tried and tested and moved from one treatment to another until we find one that suits them or that gives them more benefit than side effects. The other problem with these treatments is even if they do work, symptoms tend to recur once patients have stopped the treatment. And of course all of these hormone treatments are contraceptive, and as I say, this can often be a young population who maybe are wanting to try and have a family. This is a bugbear of mine. There are lots of patients, and I think still some clinicians, who think hysterectomy is a treatment for endometriosis. Of course, if you think about it, the disease is outside the uterus, so removing the uterus itself is not going to treat the disease. If you do a hysterectomy and remove the ovaries and you're removing the source of the estrogen, then that may be of benefit. But I think it's important with patients to try and explore other options before offering or suggesting hysterectomy to manage the condition. Now that's not to say that some patients don't end up having a hysterectomy who've explored everything else and they maybe think that this is the final treatment that's going to be of benefit to them. And certainly if patients have adenomyosis and endometriosis, then a hysterectomy can sometimes be helpful. And then of course if they have a hysterectomy and removal of both of the ovaries and are put into a premature iatrogenic menopause, then they should be offered combined HRT until the natural age of the menopause. And that of course carries problems in that sometimes that HRT then continues to stimulate the disease and give them symptoms. So the other area which is of particular interest to me is alternative management strategies involving the neuromodulatory drugs which I've listed here. Of course we have tricyclic antidepressant drugs, amitriptyline, nortriptyline, and imipramine, SNRI, duloxetine, and the gabapentinoids, gabapentin and pregabalin. And the rationale for using these drugs in endometriosis is that around 75% of patients with the condition have a neuropathic component to their pain. And of course, neuropathic pain doesn't generally respond to treatment with hormones or treatment with surgery or treatment with standard analgesics like non-steroidals. I put the opiates here, and I put them deliberately in a paler grey colour because of course we're trying to avoid prescribing opiates, but I do think they can sometimes be helpful in patients who struggle to manage flares of pain with endometriosis if they're given a sort of rescue pack of opiates to try and keep them out of hospital when that scenario arises. But I think these should be prescribed largely in consultation with a pain management specialist. The other areas, of course, psychological interventions. We have a pain psychologist in our clinic, and patients generally take up the offer to work with our psychologist. And largely the work is done around educating them about pain mechanisms in endometriosis, helping them to manage their activities, pacing, and sometimes introducing self-coping strategies like mindfulness and relaxation. Also in Edinburgh we run a pelvic pain management group, which at the moment is an online 8-week course, 2 to 3 hour sessions, not every week but over a period of about 3 months, which patients with endometriosis often find very helpful. Of course this isn't a cure, this is just to give them strategies to deal with sometimes almost constant pelvic pain. The reason that we set up one specifically for pelvic pain was that we were finding we were referring some of our patients to the general chronic pain management group, and of course some of these young women were ending up having to sit next to perhaps an older man with chronic headaches, and they often maybe want to talk about fertility issues, problems with painful sex, etc. And so this group works very well, and we often find that the patients get to know each other and form separate groups after they've been through the cycle of the course. The other area that or treatment that we offer is pelvic pain physiotherapy. We've only recently in the last few years had specific funding for this. It took a long time to get this funded, and this was largely because we're aware that patients with pelvic pain and patients with endometriosis often have a musculoskeletal component to their pain. I often describe this as if they've had pain for a long time, they have a lot of tension in their pelvic muscles, and so our pelvic physiotherapist gives them help with postural exercises, breathing exercises, and often offers pelvic floor manual therapy. The other area that's of interest to us in Edinburgh is acupuncture. Again, we're very lucky through the university. I've got an old PhD student who is qualified as an acupuncture therapist, who's continuing to work with us and offers the patients. She actually does 3 clinics a week of acupuncture. Again, this isn't a cure or a recognised treatment for pelvic pain associated with endometriosis, but certainly the patients do find at least short-term benefit from this, and often patients are looking for something which isn't surgery, which isn't pharmacological, which doesn't have side effects, and they find the sessions of acupuncture very helpful, and they often seek this themselves and pay for it themselves outside of the NHS setting. So just to finish with my take-home messages, so in any patient that presents with chronic pelvic pain, I think it's very important to consider endometriosis, particularly if there's a cyclical component to their symptoms. I think it's important to be aware when you're managing patients, and sometimes patients with endometriosis can be very challenging. They're often very well read. There isn't a one-size-fits-all model for managing the condition. I've been involved a lot in guideline development, and we're always trying to produce a flow chart to make it easier for people to manage patients with endometriosis, and we often find this very difficult. I think it's important to be aware of the limitations of current treatment strategies, the fact that surgery isn't always effective, the fact that a large proportion of patients get a recurrence of their symptoms after surgery, and the fact that medical treatment is only generally effective if it is effective when it's being taken and it isn't a cure. So patients have to be aware of that when they're prescribed it, and they also have to be aware that it often comes with side effects. I think it's important for us to realise our limitations and refer complex cases, and these aren't just complex surgical cases, but perhaps complex pain management cases of endometriosis to endometriosis centres. And of course, like all chronic conditions, we should try and offer patients individualised care and involve them in decision making around their treatment at all times. So I'll just finish there, and I'm happy to take questions for the rest of the session. So thank you.
Thank you very much. We actually have 3 or 4 questions in the chat bar, if you're able to head into there.
Right. Yeah.
First one from Agalia.
Agalia. So Agalia has said, how close is MRI to laparoscopy in terms of diagnostic accuracy? I have had patients from Europe where MRI seems to be commonly used. Well, there was a big study carried out in the UK, I think about 8 to 10 years ago now, called MEDAL, which compared MRI in terms of diagnostic accuracy to laparoscopy. And unfortunately it didn't show that MRI was particularly helpful for diagnosing endometriosis. So it's not recommended in the NICE or in the more recent ESHRE guidelines for diagnosing the condition. It is, however, useful. We use it quite a lot when we have maybe done a laparoscopy, when we're working up our more complex patients for their second surgery. So it's quite helpful for delineating the degree of bowel involvement. So the colorectal surgeons find it quite helpful, but that's, you know, a separate issue. The other area where it is helpful is if you have a patient who perhaps can't have a laparoscopy, perhaps they have a very high BMI. I sometimes use it in these instances, but I do qualify that it's not 100% accurate. Or I also sometimes use it after patients have had surgery for monitoring. Sometimes they prefer that, or they feel more reassured by an MRI than an ultrasound scan. But I have to say there's not a huge amount of evidence base for that. Next one is from Toll. Would it be appropriate to refer paediatric patients where there is a suspicion of endometriosis, even if contraceptive pills to control symptoms is effective? It's difficult. Certainly in Edinburgh, we do have a paediatric sort of women's adolescent gynecology service. We obviously don't see very young patients in our service. The youngest patients tend to be sort of 17, 18. I think the most important thing is to listen to these patients and not. There used to be this feeling that endometriosis was a disease of patients in their 30s and 40s, and endometriosis didn't occur in younger people. That's definitely not the case. I think we have to balance that against over-investigating younger patients. So I think similarly when we wrote the NICE guidance, it was directed towards younger patients as well. So a short trial of either some analgesic regime or contraceptive, and then if that doesn't work, refer to the appropriate secondary care service. Next one, sorry, moving up. This is from Agalia. What are the options for people who are TTC, especially when the waiting lists for gynecology are very long? They face the double frustration, poorly controlled symptoms and being unable to conceive. What, I don't know this expression, TTC, abbreviation TTC. Is Agalia there? Trying to conceive, is it? Guessing. I assume it's is that correct? You wanted to know about patients with endometriosis plus with infertility. In this instance, I suppose if you think a patient, if it's more infertility that's the issue rather than endometriosis, I suppose refer them to the infertility centre at first. It is a huge problem at the moment. We've got a waiting list of 2 years for a laparoscopy. And so if they're waiting for a laparoscopy for surgery to try and improve their chances to conceive, obviously this is doubly frustrating if they also have pain symptoms. It's very difficult. I mean, if surgery is the option for them, we can't really overcome that, but I would involve the fertility team at an early stage in these cases. Can I check, so if a patient has had a hysterectomy? Yeah, so we tend to, I mean, again, for the HRT regime for patients who've had a hysterectomy and had a BSO at the same time is that they should have combined HRT, and this is because of the small risk of malignant transformation of the endometriosis lesions due to unopposed estrogens. That's what's recommended. Again, not a huge amount of evidence base for this, and there is the opportunity to sort of discuss that with a local menopause specialist if the patient isn't wanting to take combined HRT. Should an ultrasound always be offered to exclude any other differentials? Yep, so ultrasound would be first line. So again, the NICE guidance is very clear about this. So if a patient presents with symptoms suggestive of endometriosis, the first line would be a pelvic, ideally a transvaginal ultrasound scan before moving on to any more invasive investigations, and probably should be done before any form of treatment, even analgesia or the combined pill, for example, is started. How early in the clinic process would you do a diagnostic laparoscopy? Well, I always feel I'm in a slightly different position here because we're almost in a sort of tertiary care centre, so a lot of patients that I see have already had a laparoscopy. But I think for me, it's all about discussing the pros and cons of laparoscopy with the patient. It's remarkable. Some patients are absolutely adamant and have read all about laparoscopy, and that's what they've come for when they come and see you in the clinic. But then other patients are a bit more ambivalent and are also happy to discuss with you the pros and cons of laparoscopy. And of course, it's not without complication. And I think particularly at the moment, because of the long waiting lists, there is more of an opportunity to discuss options to laparoscopy whilst the patients are waiting, and let them try some of the other medical management whilst they're waiting for their surgery. Next question was from, don't have a name, Samsung. Does HRT worsen the disease in postmenopausal women? It can do, and one of the things we do if a patient presents with postmenopausal endometriosis who's on HRT is we suggest a trial off the HRT to see if that relieves their symptoms. But we don't really know whether it actually has an effect on the disease itself, the lesions, whether the lesions worsen if a patient is given HRT. From Susan, we're trying to manage milder initial symptoms in primary care with the combined pill. Will not miss the diagnosis, which might have implications later for fertility. A lot of patients want referral for a diagnosis as well as treatment. So this is something we get asked about all the time, and people talk about starting the pill as masking the endometriosis. Again, I go back to the point that we don't know if endometriosis is a progressive disease, and in some patients endometriosis seems to just resolve. As I say, in other patients it does get worse. I think the most important thing is to manage the pain, to manage the symptom, because what we definitely know is if patients are in pain for longer periods of time, they're more likely to develop a chronic pain syndrome, develop other chronic pain conditions. So I think it's all about that. But I think your second point, which is that patients want a diagnosis as well as treatment, is, again, that's something to discuss with them. And if they're adamant they want referral for a laparoscopy, I think probably we should be doing that for these patients. What is this is from Ahmed Chowdhury. What's the reason for urinary problems in endometriosis? Is it due to fibrosis? It's a good question. So some patients can have endometriosis in their bladder. They can have a bladder nodule. It's not that common, but if patients present with frequency, particularly if they present with hematuria or dysuria, it's important that they're investigated. And sometimes, quite often, we do a cystoscopy at the same time as a laparoscopy. But I think one of the other reasons is around 50% of patients with endometriosis will have bladder pain syndrome, and the crossover between all the pain syndromes. So it may be that is an aspect. And there's also an increasing voice of the patients who say that urinary symptoms are part of having endometriosis, as are bowel symptoms. So I think when we think about it now, we're thinking of it more as a sort of systemic disease which can have multiple symptoms. It could be due to some scarring, fibrosis as well within the bladder or within the urinary tract. Roughly, what is the sensitivity specificity for ultrasound for endometriosis? So if a patient presents, I would avoid just thinking about sensitivity and specificity. If a patient presents with symptoms suggestive of endometriosis, and so if they have cyclical symptoms, cyclical pain, painful sex, and they have a normal ultrasound scan, that doesn't eliminate them having endometriosis, because of course 80% of pelvic endometriosis is superficial peritoneal disease, which won't show up on the scan. So I think symptoms, the scan is almost an exclusion of perhaps ovarian or deep disease or some other pathology to explain their symptoms, and the next step would be referral for further investigation if the patient doesn't respond to straightforward treatments. Agalia, building on Susan's question, how do you think we should decide when to refer people with bad dysmenorrhea, as in how do you differentiate between this and endometriosis based on the outcomes you see, you investigate? So of course, dysmenorrhea is a symptom of endometriosis. I think again, if you see a patient, so this is a patient with primary dysmenorrhea, so it's a patient who you've excluded endometriosis. Again, if you're struggling to manage these patients in secondary care, I think it's perfectly reasonable to refer them to us. We'll probably still use a similar range of treatment strategies for them, but obviously this is a huge problem and can also be really incapacitating and impact upon quality of life. And I think one of the reasons that we have a pelvic pain service is that we acknowledge that not all patients with pelvic pain, with dysmenorrhea, with whatever pelvic pain symptom, have underlying pathology, and sometimes it's the patients that don't have obvious underlying pathology that are more difficult to manage and often have the poorest management within primary and secondary care, I think. Next one is, skipping up and down. This is from Rebecca, if we have a patient who has mild symptoms of possible endometriosis, who has good control of symptoms with primary care management, should we be discussing possible impact on fertility at this stage, or is fertility related to extent of disease? So fertility isn't related to the amount of disease or the location of the disease. I think the most important thing to remember is that 2/3 of patients with any type of endometriosis won't have any trouble conceiving. 1/3 of patients who have endometriosis will have difficulty conceiving, but the majority of those will respond well to either surgery to excise the disease. And interestingly, surgery is better for superficial peritoneal disease rather than for more extensive ovarian or deep disease in terms of fertility outcomes. But also patients who need to undergo IVF because of endometriosis associated infertility do well. So I think if you have a patient who has good control of their symptoms, I think you can give them these statistics, make them aware of them, but they don't automatically need to be referred for fertility investigations. And certainly you would want to give them a period of time where they just try and conceive naturally off off their whatever treatment they're taking for their endometriosis. Does referral to BSG centres need to come from primary care, or do they accept primary care referrals? Need to come from secondary care. So generally they have to come through secondary care. So we have a problem, like I'm sure all of you do, with staffing numbers and numbers of referrals. So we have quite a strict policy that any patient who's referred to our centre has to be referred by another secondary care clinician, particularly if they've come out of our catchment area. So we take primary care, direct primary care referrals if it's an existing patient that's maybe sort of got lost in the system, or lost to follow up. In those instances, we'll take a direct referral. But if it's the first referral, it has to come from a secondary care from another gynaecologist. Next one is from Miriam Duncombe. When patients with endometriosis get pregnant, how does pregnancy generally affect their symptoms? Do they worsen? Well, generally, patients, when they get pregnant, their symptoms get better because of the very high levels of progesterone that they have in their system because of pregnancy. But there are some instances where patients who've maybe had pain secondary to endometriosis, I think, then do less well in pregnancy. And this is probably more to do with the fact that they maybe have a sort of neuropathic or an osteopathic component damage to their nervous system, making them more susceptible to pain in pregnancy rather than the endometriosis. The important thing is that never to say to patients that pregnancy is a treatment for endometriosis or a cure, because the symptoms, the disease returns as soon as they're not pregnant. But often, breastfeeding can be helpful in reducing the pain associated with endometriosis, like a sort of continuation of the effect of pregnancy. How should we avoid the issue of delayed diagnosis reported in the media whilst not generating too many referrals? Is it just those who fail primary care treatments or can't have them, as you mentioned earlier? So I'm part of a group at the Scottish Government at the moment who's looking at this. I don't know if some of you followed or read the SNP manifesto a couple of years ago. Nicola Sturgeon actually put a statement in about endometriosis. So currently the delay in Scotland is 7 to 8 years, and she said by the end of her term it would be reduced to 1 year, which is completely impossible, I'm afraid, unless we suddenly develop a biomarker in the next coming months. So we've been sort of looking at ways of getting around this, and obviously the impact of COVID on waiting lists has made this worse, and I suspect these sort of times from symptoms to surgical diagnosis are going to get even longer over the next few years because of that. So we're looking at this concept of giving patients a working diagnosis of endometriosis, so that just making sure that the condition's been discussed with them, they're aware of why they're on their treatment. Because I think some patients don't understand when they're given the combined pill that it's because you suspect they have endometriosis. So it's all about that sort of, if you like, label of potentially having endometriosis that I think is important. So the Scottish Government are going to be producing some guidance around that. So I think it's not patients. I completely understand the challenges that you're having at the moment in primary care, with the sort of delayed time to referral, and also the fact that we might see patients and put them on the waiting list for surgery, but then they're back in primary care and you have to manage them over that 1 to 2 year period of waiting. So we are trying to address that in discussions when we list our patients and talk them through medical management so that they can try whilst they're waiting for surgery. What is the prognosis of endometriosis? I think that's a difficult question to answer, because as I say, we don't know the natural history of the condition. The majority of patients do get resolution of their symptoms once they've reached the menopause. But one of the things that we're learning more and more about endometriosis is, because it is this systemic neuroinflammatory condition is that, as well as making patients more susceptible to other chronic pain conditions like IBS, bladder pain syndrome, fibromyalgia, they're also susceptible to a range of other conditions. They've got an increased risk of cardiovascular disease, they've got an increased risk of autoimmune diseases, increased risk, for example, of rheumatoid arthritis, and they also have an increased risk of certain cancers. There's quite a lot talked about the increased risk of ovarian cancer, and that risk is nearly doubled, but you've got to remember that the risk of ovarian cancer in this population is already very low, so it's that sort of whole relative risk thing. And then there's an increased risk of melanoma in patients with endometriosis as well. So, difficult question to answer, I think. That sounds good. Is the biomarker likely to come about? I hope so. We've done quite a bit of work in Edinburgh trying to identify a biomarker, and we're currently working with Roche Diagnostics, who did a big European study to try and screen a panel of biomarkers that they had to see if they could develop almost like a traffic light test for endometriosis. And they think they have got a test. I don't know what the biomarkers are. I'm on their advisory panel, but as you can imagine, it's all very secret at the moment. But we are currently recruiting patients across the UK to then test that biomarker test. So these are patients that are entering our ESPRIT 2 surgical trials, so they're also going to be giving blood samples towards this piece of work. So we're hopeful. There is a group in the States who've identified a microRNA biomarker. It hasn't been tested in a huge number of patients though, but they've put that out to market. I think you can now buy the test if you live in Sweden. So there are biomarkers, I think, definitely on the horizon. I think other than blood and urine biomarkers, there is also a lot of hope in the fact that imaging is getting better and better. And as they say in Canada and in London at the moment, there are two groups who are working hard to train radiologists, sonographers to better identify endometriosis and putting together a range of guidelines. So perhaps we'll see a swing towards better imaging diagnosis before we see the blood biomarker being developed. I can't see any more questions in the chat, so I don't know if people have other questions. Can I just ask a general question? So obviously I sit on the other side, sitting in secondary, tertiary care. How are you all coping with the waiting lists and the impact the waiting lists are having on patients with suspected endometriosis? Is that being a big challenge for you? Or patients who with known endometriosis waiting for surgery? No answer.
Please feel free to unmute and answer, Andrew. Rather than type.
Or type. Typical frustrations that patients come with, yeah. Saragaya has written, patients come and ask to expedite review or go private. Some are frustrated with trying treatments. We try to placate them, yeah. I think we're finding quite a lot of patients, sadly, particularly a lot of patients who I think probably can't afford to are seeking private treatment, private surgical treatment. A lot of frustration. We get lots of patients phoning our secretaries, on a daily basis to see if they can be moved up the list. It's very challenging at the moment. Okay. Is there anything you think we could be doing better from the hospital care setting, apart from trying to shift the waiting list? Yeah, social media and headlines about delayed, yeah. I completely agree. I think that's why we're trying to move away from the diagnosis being all about the surgery and move to this working diagnosis, so that I think it's about patients realizing that the doctor is thinking about endometriosis and not that it's never been mentioned to them for that sort of 7 to 8 year period. Yeah. Yeah, I think social media is very challenging. There's obviously a lot of patient support groups, patient advocates. Lots of them are fantastic, but then there are one or two that are kind of stoking up some of the problems that are going on. It's very difficult dealing with the whole social media and the press as well. The press always want a bad story rather than a good story, sadly. Useful to access advice while waiting. So we put together, if you look, we've got our website's www.expectedinburgh.co.uk, and we put together some sort of self-help advice for patients during lockdown, which is largely about all the treatments that they can access sort of out of hospital. Some of those treatments obviously they'd have to access through yourselves in primary care, but I think a lot of that information probably still applies, particularly to patients on the waiting list. So I'd advise you to have a look at that. Early patient education sessions could have an impact on patient. Yeah, so we've had quite a lot of discussion about whether we encourage our patients to see our psychologist and attend a pelvic pain programme whilst they're waiting for surgery, because before, largely due to resources, it was a sort of a last resort. But I completely agree. I think if we could give them, the education around pain first, that would be very helpful, and that is something we're exploring. Good. Cutting down on the first assessment waiting time. Yeah. I think the first assessment waiting time is going to come down much more quickly than the surgical waiting time, so hopefully that will happen. That's a good point. Any other comments or questions from anyone?
I will share your web address with all of tonight's attendees. We can also talk if there are any key resources that you think that we should pull out from your presentation. Obviously, tonight's guests will get this recording, but if there's anything that I can fire it out in an email, we can discuss that.
Yeah, I can give you, there's a module that the Royal College of GPs put together on endometriosis, which hopefully you've seen, which is very helpful. It was directed by Endometriosis UK.
And just a couple of thanks for you in the chat there. Any last questions from our audience tonight?
No.
Really helpful. Sorry I missed the first 10 minutes, but thank you for answering all these questions. Thank you. Yes, no, I think this question section has been really interactive and obviously very thought-provoking from your presentation. So thank you so much for your time.
Pleasure.
And yes, as I said, this has been recorded, so we will share that with you in the coming days. We will also be in touch with some feedback, both for the college and for our speaker tonight. Susan, I just asked a question there about good patient resources.
So NICE produced a patient guideline as well. So if you look at NICE, and then I think ESHRE have produced a patient guideline as well. So that's ESHRE. They're the two main, the ESHRE guidelines, the European guideline and the NICE guideline, but there's definitely a patient guidance.
Everyone, well, if we have no more questions for Andrew, I think we will wrap it up there. But at the college, we do anticipate having a few more women's health related webinars. So if you would be interested in hearing about those, please do email scotlandevents@rcgp.org.uk. Sorry, I almost forgot that there. And we can keep you abreast of all of those details as they come. But once again, thank you so much for joining us, and thank you to our speaker, Andrew. Thank you so much for your time tonight. And yes, hopefully we will see you all on a webinar very soon.
Thanks. Good night.